Hey everyone, welcome to today's episode 121 of the Cup of Nurses podcast with your hosts. Thank you guys for tuning in. Those that are new, welcome to the Cup of Nurses podcast. As always, cupofnurses.com and weareforlandwarriors.com for any info on us and the latest merchandise that we're wearing here. Farland merch is out. And also our Facebook groups are out. So come in there, interact. Everything should be updated with the link. So just click on the episode and you'll see the link to everything that we're talking about. And as always, if you guys like the episode, don't forget to give us a 5 stars because it motivates us, ranks us high in the algorithm, and then we keep on producing this high quality content. How you doing today, Pete?
I'm doing great. And shout out to you, the community. Those 1,000 plus subs got that benchmark. But today, a nursing filled episode. We're going to talk about cold blues, the do's and don'ts, a little bit about the ACLS protocol, and the roles of a nurse during a cold blue. So a very informative episode for today.
I think everyone should know this, especially you hear about it in school when you're coming on. Sometimes you're a med-surg nurse. You don't always experience these things. And especially having your first code, you freak out, you panic. You forget everything that you remembered so hard that you worked 4 years to remember. Yeah. And in that panic, you got to know what to do. So in today's episode, we're going to cover all that.
And unfortunately, it's one of those things where you're going to get better at it as time goes on. This is the only way you're going to go to learn how to do a proper cold blue, just to experience it. Just because every cold blue is different, even though we have our own protocols and steps to follow, each code is completely different. And I'm sure you could vouch for the same thing. You have different set of nurses. Sometimes the protocol gets followed, sometimes it goes off track, and just communication is great one day, other days it isn't. It's just one of those things where it's unpredictable and it's just learn as you go.
So when it comes to code blues, I think the first thing we have to talk about is prevention. So you want to prevent the code from actually happening before getting hands-on and getting all excited, because you don't want your patient to go to that degree. So you're going to call your RT before that even happens. But ultimately, you should be rounding on your patient more often and get that first physical assessment. I think that's the value of everything as a nurse. And as a beginning nurse, nail your assessment, know the baseline of your patient. So when you go back in, you know that, hey, something's off, and you might be using your intuition or get some orders just so that things don't proceed and go the wrong way.
Exactly. And know a little bit of background too, because a lot of times labs get missed more often than you would think. Something so simple, something that can be fixed in quite a quick manner is usually the culprit of these codes. I don't want to say usually, but about I want to say 20%. As much as codes I've run and I've done, probably like a good 2 out of 10 have been for sure related to labs. So you gotta be careful, just because just one lab, it could be potassium, he could be hyperkalemic, and you could throw your patient into abnormal rhythm like pulses, VTAC, VFib if they have low mag, they go to torsades, other rhythms like that, and usually and unfortunately a lot of times those result in death, because it's a lot easier for us to prevent it than treat it once it's happening.
Yeah, and especially when orders get missed and things like that when it comes to labs. Sometimes a nurse will replace potassium, replace mag. They're never going to call and order the follow-up. And sometimes it could be missed during the report. There was so many times that I'm looking at my morning labs as a day shift nurse now, and I'm not sure if night shift maybe replaced it or vice versa. And it's just like, okay, you wait for it, or you could be that nurse and be proactive. The way I like to go about things is everything okay with my patient? I'm not going to maybe proceed sometimes. I'm using my common sense judgment. If I feel like there's, PVCs, PACs, I noticed the mag was 1.7 before, I'm going to maybe do some interventions and get a lab value. In the ICU, it's always easier because we have like PICs and central lines and A lines and just troubleshoot,
Right. And assess your patient on acuity as well. When you come into work, to your shift, and you've been doing it for a few years, you know which patients give you the sickest. You know which one's going to give you the hardest time, which one's the more critical, which one's the more needy one, and you can assess that. And a key thing to do is always prioritize and keep that really sick patient always in mind, because patients, even when they're borderline healthy and ill, they could flip. And if they're really sick, especially in the ICU, they could go south any moment, anytime.
Yeah, and especially with the respiratory patients, so secretions and things like that, we neglect that so much. Oral care, it's so valuable, especially in the ICU, to prevent pneumonia. And in all the units, so many times I saw codes just for bad oral care.
Mucus plugs.
Aspiration pneumonia, mucus plugs, like you name it. things that could have been prevented. And, poor patient, now they go through the suffering, they get pneumonia, they're intubated, they get septic on top of whatever they came line that we have to treat. Now we have to treat sepsis first before, underlying issue happens. Now they're needing CRT or dialysis. The list goes on. And once you get to that level, there's so much things that hit the fan. Mortality is high. So prevention, as we can't stress enough.
Right. So what to do when you experience a cold or you get yourself in a cold situation? The first thing, it's easier said than done, is to stay calm and assess the patient just to make sure that, especially if you're the one walking in the room and about to call the code, make sure you stay calm and actually check on the patient. Sometimes they could be sleeping. Sometimes people sleep in like a weird fashion where you think are they like breathing or not sure. Assess them before you press anything.
Because or the monitor, right?
Or the monitor, yeah. Does a monitor align with your evaluation? Is there like a weird rhythm going on and a patient's acting strange? Like assess the situation before you press any buttons, because once that button is pressed, the whole hospital is on alert and they know that there's a code going on in that room.
And you don't want to be that nurse that calls the rapid response or code blue for maybe a patient that you thought that was unconscious or that was just maybe the leads were off or whatever it is, and you just freaked out and panicked. So on top of, what to do during a code, after you made your assessment, you're going to press the button and a team is going to come. Make sure you don't leave the room in this case. I think you should be always with the patient. We can't stress that enough. Scream if you have to. The code blue was already pressed. They know, and they're going to come. Stay with the patient and do the most important thing, which is maybe lay the patient flat, prepare for CPR. If not, initiate CPR right away.
Yeah, and then slap on those pads, get them hooked up to the monitor if they're not, because in a cold situation, the first thing you're going to basically assess besides the patient is a rhythm. Is it a shockable rhythm? Is it a non-shockable rhythm? So if you throw the pads on a monitor, you're doing CPR and you're reading the rhythm, and let's say it's VFib, ventricular fibrillation, or pulses, ventricular tachycardia, those are shockable rhythms. So you're going to want to make sure the defib's on versus your non-shockable rhythm, which is your asystole or PEA. And those you're going to focus more on CPR and epinephrine, not so much the shocking aspect.
Yeah. And I also noticed not all codes are the same. Some hospitals, they go into the AED mode where the monitor says, analyzing heart rhythm, stand back, and sometimes they'll tell you an advice to analyze or give the shock. Some places, the intensivist or whoever is the doctor that comes in for the code is going to be calling the shots. They see the monitor and they're going to assess the patient, whether it's, shockable rhythms like VTAC and go from there.
Yeah. So if in a cold situation, if the rhythm is a shockable rhythm, you would start CPR, do CPR, check the rhythm. You obviously have the monitor on and the pads on. Then once it's a shockable rhythm, you go ahead and shock between like 120 and 360 joules. If it's the VFib or a pulse's VTAC. Then once you shock them, evaluate the rhythm. If still nothing comes back, keep doing CPR 2 minutes. And then once again, evaluate the rhythm, shock them if it's a shockable rhythm. And then you're also going to be administering epinephrine every 3 to 5 minutes in between those shocks and those pulse checks.
Yes, and make sure while this is all happening, there's somebody that's finding out the IV access. Usually the primary nurse that had the patient should be letting everybody know in the room what IV access they have. We're going to get into roles in a second, but if they don't have an IV access, there has to be 2 people on there. Sometimes you might even go the IO route. Not all hospitals do this, but actually had the experience to put in several IOs.
Right. And if you're gonna go the other route, which is the non-shock rhythms, which is your asystole and PEA, this is just going to revolve around performing CPR, proper breaths, and epinephrine to hopefully restart that up. So if it's a non-shock rhythm, it's a little bit easier to remember. You're just doing CPR and pushing epi.
Yeah, and as things go on, and there's no improvement, you're going to go into the reversible causes, which are the H's and T's. And I think we did a podcast already covers all that, so we're not going to go into depth of that.
Yeah, pop the episode in the show notes. You guys can check it out.
Exactly.
Yeah.
So now we have what are the roles during a code blue. So the best way to do this is organization. So we figured out as things go on, it's better to assign people. Sometimes with the crash cart in hospitals, I've seen people that wear name tags. So they already have assigned roles as lead nurse or, who's going to be the recorder and things like that, just so you could pinpoint them in the room. I think it's more important for day shift because as a night shift nurse, the experience, you don't have as much people in the, in the room when there's a code happening. Yeah. During day shift, it's literally people glued to the wall looking, and it's organized chaos at its best.
Yeah. Both have their positive and negatives. Like Matt said, on night shift, less staff, so less chaos, but you really have to know what you're doing to be efficient. Compared to days, you're going to have a lot of support and sometimes too much support that might get in the way, and you might not need to know everything. But the first role, we'll just start with the lead role, the lead nurse. This is the nurse that comes in and tells everybody what to do. And it's usually the primary nurse, because usually the primary nurse is the one that finds the patient in cardiac arrest. So once nurses flood the room, she's going to assign roles. You start CPR, or you help with CPR. You start getting IV access. You start recording. And she's the one that's going to dictate when to push meds and ultimately wait till a physician comes in or somebody else that's going to take hold of the situation.
Yeah, and in most hospitals, usually the RT nurse that already is assigned for that position is going to come and be the lead nurse. In some instances, I noticed, even at the previous employers I worked. And when we travel nurse, I think we saw the same thing, correct? Usually the lead nurse, we worked more in the ICU, so we didn't see that aspect of the care. But usually there was always somebody in ICU that was like an RT nurse. And if there's a code, they go right away, and they're usually the ones that are in charge of running the show, aside from the doctor.
Yeah. So some do's and don'ts if you're the lead nurse is you want to you want to be assertive in the room. So speak clearly, make sure everybody knows that, hey, you're running this code right now. Like I said, speak loudly. And then if you are also a primary nurse and a physician comes in, you're going to be the one that's going to answer questions. So make yourself available.
Yes.
So if a physician walks in and somebody else takes over, then you could step out and inform everybody what happened, what's going on, because you're going to be the best resource in figuring out what happened to the patient.
And you make a very good point. Even though there is a lead nurse assigned, be the leader if this is your patient. Just like you say, speak up, open up, be available, let people know what's going on, because you're going to have the best value and opinion on what's going to happen, because you just were with the patient 3-4 hours and saw the decline, or maybe you could hint them that, hey, maybe it's the low mag because the mag was 1.3 and I don't know if anybody replaced it. So now you're showing your honesty. We could troubleshoot. Labs already there. We're getting labs. They're freaking run stat, and we could figure out and reverse the cause of this code blue.
Right. And don't try multitask and don't leave the room.
Yes.
At this point, you're probably already a few minutes in before the physician walks in. You have enough support. You could dictate somebody else to take over, and you just help figure out what happened.
The next role that's going to be very important is the IV access and medication. Sometimes that could be the nurse that comes in, that's the RT. In the ICU, I feel like everybody hops on the IV access. That's like the best thing to do, and it's fun sometimes, to be honest. So you're going to make sure there is an access, just like I said. If there's 2 nurses starting an IV, you can't get anything. You go for the IO route, which is intraosseous. You're going to drill in the ankle and into the shoulder, flush it, and establish a socket where you could flush medication through the bone marrow. And have the crash cart available to you as that nurse, or have somebody handing you things. Make sure you always have flushes open. That's another big thing. And sometimes during this chaos, not everything is pretty. Assess where the lines are going, because sometimes there's propofol running. As the IV access nurse, think about what's running, maybe shut that off, tell them to maybe crank up the pressors, because sometimes that primary nurse is freaking out and not thinking. So take that role of what's going in and out of the patient, or sometimes maybe you have to clear up your line, unplug everything, and have a straight, firm line ready to go.
Yeah. Some of the do's and don'ts of IV access nurse or the medication nurse is, if you don't get the line on your first attempt, just keep trying. Like, this is an emergency situation, just keep trying. Don't give up at the first attempt. But also, if you're struggling, let somebody know. There could be 2 nurses trying to hit an RV, or not hit an RV, but
geez.
right, hit the right ventricle. There could be 2 nurses.
I was thinking like RV, like we just took an RV trip. That's what I was laughing about.
Oh, that's so funny. Yeah, there could be 2 nurses that are trying to start an IV at the same time. So that's okay. We just need the access. And also, once there is access, only 1 nurse should be pushing the meds. And some tips on pushing meds is always keep the vials with you, just because sometimes things get lost or things don't get noted properly, and you have to look back on what you gave, and it's really hard to remember. So just pop them in your pockets. And also, if you're going to drop 2 meds at the same time, try and keep them separated so you know which one's what. Like, if you're going to give like etomidate and fentanyl, keep the fentanyl always on your left-hand side and etomidate on your right, just so you know what you're giving and what amount.
Yeah, and sometimes what I like to do too is just tape the vial around the saline flush.
Yeah, because you keep pushing.
That's my thing.
Yeah, it's same. So because you could be pushing a lot of meds because you're going to probably be pushing the epi. You're going to be pushing any of the sedation or paralytic when anesthesia comes to intubate, and then you're also going to be push amiodarone. You're going to be hanging meds. It's going to be get to a certain point where it might be a little overwhelming sometimes, depending on if the code draws on for long amounts of time.
Yeah, and that's one thing actually we didn't mention because we're going in line here, but when it comes to the whole code blue itself, as you're doing CPR and all this is happening, we're all thinking about the airway, which is more of a respiratory therapist role. But if they're not intubated in the ICU already, we're getting a gyroscope ready for the physician and Mac blade, and they're trying to go and establish airway because that's going to be higher quality.
Yeah, and the breaths, if you're bagging a patient, it's like one breath every 6 seconds, like one breath every 5 to 6 seconds. And the compressions, you want to go to 100 to 120 a minute with like a 2-inch depth.
Yeah,
I just want to touch on your compressions. Going back to the medication and the IV access, let people know when you're pushing these meds because the physician is going to tell you to push this, and sometimes they get the meds confused. So you always wanna reiterate what they told you to push. So 50 of Fent, and I don't know, 25 of propofol or something that random sometimes they assign you.
Yeah.
And then and let them know, hey, I'm pushing this and how much, just so everyone's aware.
And this goes into the next role, which is you have to be verbally expressive because the recorder needs to be documenting when these medications you're giving. You're intubating, you're giving 20 etomidate and 5 of Versed, let's just say, at 9:18 p.m. That has to be documented. And especially when it comes to the medications, you're pushing epinephrine because they're going to be asking you how often you're pushing the med. And even as a recorder, when I was younger as a nurse, I always hated having that role because I always wanted the action. I was like, I don't want to be a recorder. Sometimes I got left with that task when I walked into the room. But it's a very important role. And once you get older and more experienced as a nurse, I genuinely like to do it sometimes. And it's also another role in leadership. And all these roles are actually leadership roles because as a nurse, that's what we're doing. You're going to want to let the physician know, hey, it's been 3 minutes since the epi, or give updates. Sometimes the physician is going to be asking you, what the time is. So one of the do's and don'ts is make sure you're watching the clock. Have it available. If you don't have a watch because you forgot it, how that goes sometimes. Make sure you have a clock visible or ask somebody because that's valuable information.
Yes, and the only thing you're going to remember everything, make sure you write it down. There's times where when I've been recording, I literally wrote down on the code paper, and then I was also writing down at the same time on a whiteboard, because in the rush of things, sometimes the paper falls down and you still got to record, so you're still trying to catch up, and it could be a mess sometimes. So if you think you remember it, don't always write it down, because sometimes codes can last half an hour, they can last 15 minutes, they can last 5 minutes, but still, the longer it draws out, the more likely you are to forget it.
Yes, and as a recorder, you're going to be writing down vitals, the heart rate, if what was given, EKGs, lab values, but most importantly, vitals I want to stress about here. You're going to be in charge of that monitor. If you're in the ICU, make sure you go switch your things every 2-3 minutes. You're actually seeing those numbers and you're going to be able to document them. I think usually when it comes to the cards, it's already standard, it's getting pushed. But if you have a room with a monitor, make sure it's changed or frequency, or adjust alarms sometimes because there's already so much stress going on. Take a look and silence that because no one else is probably thinking about it in the room but the person that's recording.
Yeah, could have said better myself, Matt.
Let's see if there's anything. Yeah, keep it. Yeah, and know the cardiac arrest algorithm, which goes back into knowing when to tell the physician the meds are being ready to push, or think of anything else.
Right. The next role we have on hand is the compression master, and that's probably every dude's favorite role. I always like doing compressions. I'm sure you like doing compressions.
Crack some ribs.
Yeah, I don't do compressions just to crack the ribs. It's just like you do compressions and you get them back. You're just like, hell yeah, you give good compressions.
I'm talking shit, but at the end of the day, that's what saves people's lives is the compressions.
Yeah, and it's great. It feels good. Just like, hell yeah, dude, I've just done like 3 rounds of CPR, or sometimes it's like 6 rounds of CPR back to back with somebody else, and you're just like, damn, we brought him back. It just feels amazing. That's why dudes like to do CPR, I feel like, because they want to be like the one that fixes the situation.
Yeah, and the do's and don'ts here is clearly, right, dudes have ego, so know when to lay off the chest. If you're tired, maybe it's not a full 2 minutes, who gives a shit? Switch, because it's at the end of the day, it's the patient's lives. And I had so many funny times of doing CPR sometimes. Like I had glasses on, and like I'm doing CPR and I'm running it, and my glasses are slowly coming down, 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 and then I tell somebody to yank them out because they're just like swinging like a swing when I'm just pumping, the chest.
It's fun because you're like right there on the action, and when crazy things happen, one patient that I had, or I was there during a code, we literally opened up his chest. He was a post cardiac surgery, so he had a wound vac on his chest, so it wasn't hard to open, and we literally opened him up bedside while I was doing compressions. The physician was literally shooting epinephrine straight into the heart, and in between I was doing compressions, and that was probably the coolest thing I ever seen in my life in a hospital. Besides like seeing an LVAD being placed in a heart transplant,
Jeez.
but bedside is probably the coolest thing I ever seen in my life, and that was in California while travel nursing, and that was such an amazing experience.
Yeah, even like I've heard about the cardiac thump, which was like a funny thing we're laughing about. Suppose if the patient's like in VTAC, and they were getting ready to like go into the room, it was like COVID, so they're just kind of like trying to dress up, and the physician's like, seriously, do the cardiac thump, and he tried it, and it's like you just basically take your fist and just hit the freaking patient's chest, and in reality, it should reset the electrical pulse rhythm.
Yeah, that's wild. I never done it before. I never tried it, but there was a guy in where we used to work in Chicago. He did it a few times. I think he did like once or twice.
Yeah, the last time a patient died on me, and this wasn't Code Blue, but it was the most recent contract. It was day shift, and I got rid of my patients, and it was like 2 o'clock. I got a report on the patient that basically was on a balloon pump, and there's not much we could do. Like he's maxed out on pressors in the 60s, but he was a partial code, and like within the hour, I looked at the monitor and it was just pulseless, and I didn't know what to do, man. I was in a state of panic because I just got a report. I wanted to read what's going on, and I assessed, and I'm just like, I don't know if he's dead, if I should do something. So I'm just like, checking the femoral, the carotid. I'm just like, okay, it's okay. He has a DNR. But it was so hard for me to accept that because I was just like in such heat of the moment.
Yeah, it's always scary because, especially when it happens so quick when you just get on shift, because you probably haven't even checked fully. You probably are told he's like a partial code, but you probably haven't even got a chance to look if what's partial about it. Is it
Yes.
no CPR, no certain medications, or no defibrillation? So it's very scary because your first instinct is to, hey, we gotta do CPR because the patient's coding.
Yeah.
That's first thought, and that's one of those nursing moments where it's just like you have to very quickly assess the situation, and if you're not sure how to answer your question, better check the chart and then come at it. But it's got to be done quickly because shit is hitting the fan right now.
Yeah, and I had those situations too, like, geez, it's already change of shift, and I'm in the break room, I'm having like a quick little snack of ice cream, and somebody like walks in and opens up the door like, hey, is this your patient? Okay, this rhythm is happening. So I go run into the room and I'm like, fudge, it's happening. But it was like a silly partial code thing where I was forgetting the status. I'm like, let me go find out if I could shock this person. So they're bringing the crash card in. I'm trying to check. So yeah, codes are an interesting thing. And like what we can tell you guys is you're going to get better with experience.
Oh yeah, it's one of those things. It's just, you get used to them, you get to know the flow of them, and you already have expectations of what's going to happen, and usually expectations are true. You're already going to put in certain labs, you're already going to be grabbing certain things with time.
Yes. And the next role is going to be a runner.
Or a helper. You don't want to hurt anybody's feelings.
Exactly. Or a nurse extender, whatever the proper role is for those roles. You're going to be giving out meds, maybe running back and forth, grabbing the EKG. I almost wanted to say bladder scanner, but you don't need it in this instant right now.
Maybe when you get ROSC.
Yeah, maybe when you get ROSC. Maybe you got to put a Foley in. But you're gonna be mostly grabbing meds. Maybe it's even talking to the family sometimes, which is another role. And make sure you're very familiar with the unit. If you get assigned that role, I feel like as a travel nurse, you get stuck sometimes because you're always helping out or you're like in a sideline. Make sure you know everything because you got to override meds into PICSs sometimes, and you don't want to delay the care for the patient, especially during this time.
Yeah, you're the helper. You're kind of the one that's going to help with little tasks that people need that can't leave the room. A lot of times it's calling x-ray to make sure that the tube is properly placed. It's putting in lab orders, putting in whatever orders the doctor is saying, grabbing an ultrasound, and majority of the time it's grabbing meds, starting A lines, just little things like that where you're not pulling any nurses out of the room for things. You're grabbing the amio that was sent from pharmacy. You're grabbing another bag of epi, or you grab rapid infuser, just things like that. Minute things that are very important, are needed at a ASAP. And some do's and don'ts for this role is if you're going to get a med, let somebody know, hey, I'm going to grab amiodarone. That way you leave and they know, hey, Matt's getting amiodarone. So no one's asking, hey, is anyone grabbing amiodarone? Because no one's sure of why you left. Matt just left. He went to grab something. I don't know. Well, what's the point of that?
Yeah, and also as a runner, take this leadership role where watch over the unit. There's going to be multiple nurses in that room during a code blue, and in the ICU, it's already like a given. We already do it no matter what. We always watch each other's patients. But wherever you are, just check up on your, other nurses' patients, the rooms, maybe check their pressors, check everything's okay, check the alarms if they have to. Whatever the needs are of the unit, tailor to that. Yeah. Because they're busy doing their thing, and this is your role as a runner.
That's a big thing you brought up, and I'm glad you brought it up because that's one of the things that they missed. You see like 11 nurses in a room, and it's like, hey, who's watching your other patients? And everyone's looking at themselves like, oh shit, no one's watching other patients. And then, just because you want to see a code because they're very exciting and they're very, it brings up your heart rate and something you want to partake in, don't forget the other patients because you don't want to be running a code overstaffed and then you have another patient fall or another patient, start bleeding from somewhere, pulled out their lines or even code themselves.
Yeah, and those are one of those tips that nurses are going to respect you for, and they're going to notice those things. Those are things that maybe sometimes are unnoticed, but as a traveler, that's how you develop good relationships on your unit, and then people do things for you too when you help out. So as a runner, do that.
Yeah. And also, sorry, one more thing about do's and don'ts is also recognize when you're not really needed anymore. Because there's going to be a time when there's like 3 or 4 people doing tasks that have to be done, and there's 3 or 4 people that are needed to do these things. But as the code moves on, things kind of get less chaotic, you could say, and you're going to only need 2. So recognize when you've already helped enough. That way you don't just add into the chaos that's going on in the room.
Yes, 100%. The next role is going to be talking to the patient's family. I think this is a very crucial role. It takes a lot of skill, communication, and high level of emotional intelligence. Because during these times, it's really hard to tell the family, explain the situation. But you have to be very honest with what's happening. Give them the realism of the family is in critical condition. This is what's happening. I always say we're initiating CPR, so we're cracking the sternum and pumping the heart full of blood. It also depends on how the family is. If there's somebody that was very stubborn of letting them go and they don't have realistic expectations of this code, I'm very surreal with them. Like, we're breaking her ribs and things were never going to be the same, especially when it's very long down the line. You have to be very honest with them that it's been 30 minutes, let's just say, and there's nothing else we can do. And sometimes let them talk to the physician, or maybe escort them in and out of the room. You're going to be doing that as well. There's times that the family wants to watch the code. Usually it's very hard for them. Maybe give them a box of tissue or just take them out and explain, calm them down, talk them over, explain them what's going to happen in the next few minutes. Give them some kind of trust and care for them during this time.
Some of the do's and don'ts with speaking to the family, the main one, and I can't stress this enough, is be honest. Don't give them any kind of false hope, saying that, things are doing good, we're doing good compressions, and things like that, where it's not going to end that way. You don't want to give them any kind of false hope. And also, if you're speaking to family and let's just say they're in their car driving, you can hear it in their car, ask them to pull over, or if they're not far from home, they can call you back in a few minutes. Because there's been one time that I heard a nurse tell me a story that some other nurse broke some news to a family while they were driving and they ended up getting into a car accident, so that caused a problem. So also be a little bit insightful on where they are in their environment. And also who's around them. If they're on speakerphone, tell them if they could step away and you can just speak to them directly in those emergency situations. And honesty also involves saying you don't know or you're not sure. And a physician is going to be able to provide you better information than myself, because you don't want to tell them something you are not sure about. And always delegate to the physician. If you're not sure how to answer the question, the physician is there as well to speak to the family. So just push it on them if you're not sure. And ask for help. If you're not sure on how to talk to a family, or it's your first time, maybe a nurse could walk you through it, or maybe they could just do it for the first time and you could listen in on how he or she does it.
Very good point. And just to kind of summarize everything with these roles, if everything went well and you establish ROSC, next thing during the code blue is you're going to be maybe getting an x-ray. Maybe you're going to be putting an OG in. If you're working med surg or other units, you're going to get the patient ready to transfer them down to the ICU.
Yeah, there's definitely a lot of steps post code, especially when you get ROSC. Probably another good episode that we could probably do.
Yes, definitely. And back to this role with the speaking with the family. What if the patient doesn't make it? Be very comforting. Give them time. Let them know that they're going to be going to the waiting room just so we could stabilize the patient, clean them up, because they asked. The room has to be comfortable and welcoming to them. They don't want to see all the blood and the crazy caps and syringes everywhere. And that's a code blue, ladies and gentlemen. It's a wild experience. Just think, like, what I just said right now, I just had like a flashback of like 10, 15 stories, or my first code blue on Christmas Eve that like the family ran in and they're like crying on their freaking knees in front of the bed and security's there, and I have chills right now, and I'm like, wow, nursing is wild.
It's crazy because I had to withdraw care on a patient during Christmas. So it's wild that you had to go through something like that too.
Yeah, and then the same day you sit down with your family and you eat, and that's just like the ultimate gratefulness that nursing gives you. It's an emotional roller coaster.
Yeah. Thank everybody for your time. We went over the do's and don'ts of cold blues, some of the roles as a nurse in a cold blue, and also how to talk to family during or post cold blue.
And if we missed anything, let us know. Or if you have any interesting ideas of other episodes that you would like for us, shoot a DM, shoot a message on YouTube, on Instagram, email us if you want to, info@couplenurses.com. Thank you for your time, guys.
Thank you so much. Check us on YouTube and go check out our shop.
Peace.
Woo.